Hi, very good morning, everyone.
Yeah.
Today is 27th of July, 2024. We are yet again live on another session, which we talk about diabetes. And today we have among with us Dr. M.V. Ram Mohan, and he will talk about growth hormones deficiency in adults. He's a consultant endocrinologist and diabetologist at Diabetes and Endocrine Clinic at Nellore, Apollo Specialty Hospital in Nellore, and uh, he has been DM endocrinology at Andhra Medical College, Vishakhapatnam. Sir, over to you.
Yeah. Thank you, Saurav, for a nice introduction. We'll share our screen. Yes.
Sure.
Yeah. Hope my slides are visible to you.
Yes, sir.
Yeah. So is it in the full screen now? Perfect.
Yes, good to go.
So good morning, all. It is indeed a pleasure and honor to be on this platform with all the international delegates and faculty. And thank you for this opportunity, Saurav and team. So today's my topic is on overview of adult growth hormone deficiency. We know that we deal with growth hormone deficiency in children regularly. The new entity is called adult growth hormone deficiency, where more and more cases of growth hormone deficiency or adult growth hormone deficiency are added every year. And the issues we'll be discussing next 15 to 20 minutes will be how this adult growth hormone deficiency presents to us, then how to diagnose this, then what are the current treatments modalities available, and what are the benefits of this treatment, then how to go about the challenges related to these treatments, and what are the solutions for the challenges occurring during the treatment. So we know that with growth hormone deficiency in children, as the this, if you see this chart, as the chronological ages increases, the height is subnormal, and when we start the treatment and diagnosis properly, the child goes back to the normal height. This is how we treat growth hormone deficiency in children. And what about this in adults? Well, let's know. There is a growth hormone deficiency syndrome in adults, and this will like a syndrome where there is a complex of increased fat mass, decreased muscle mass, decreased energy, and there is increased fatigability. There is decreased BMD, bone mineral density, poor quality of life. And if you treat this condition, it may reduce these aspects of growth hormone deficiency, and the therapy is shown to be effective in adults found to be truly growth hormone deficiency by diagnosing properly with appropriate testing. You can't generalize that everybody in adult will have a growth hormone deficiency. So you need to have a proper diagnosing and appropriate testing before starting the treatment. So coming to the prevalence and incidence of adult growth onset growth hormone deficiency, it is around 2 to 3 per 10,000 population. And we have two types: childhood onset growth hormone deficiency, the people becoming adults, and adult onset growth hormone deficiency. In adult onset, it is around 1.9. It is around 1.42 in women, men and women. The phenotypic features differ between childhood onset and adult onset growth hormone deficiency because the childhood onset growth hormone deficiency have a different etiology compared to the adult onset. So testing for growth hormone should be happen only if a decision has to be made to treat the deficiency. And if it is found, then the questions are whom should be tested, when should such testing should occur, and what test should be used, and what are the criteria should be used. Is this criteria same for all ages or same for all BMIs? So you should know that how to properly test the growth hormone deficiency is very, very important before starting a treatment. So we know that in childhood growth hormone deficiency, we have etiology of most of the patients are having idiopathic etiology. Which is the general causes are like genetic defects, and then we have organic like infections, craniopharyngiomas, tumors, irradiation, CNS defects, septo-optic dysplasia, structural defects. All these structural or the infections which will be affecting the pituitary hormones will lead to growth hormone deficiency in childhood. Then coming to the transition period, this is the period where the child in the late teens will be becoming an adult. So mid-late teens to until 6 to 7 years after achieving the final height, we call this as a transition period. So this coincides with the pediatric to adult care, transition from pediatricians to adult care, and often coincides with the loss of parental supervision or care, mainly because of the college days. And for the children with growth hormone deficiency, considerations for retesting and continuing growth hormone deficiency should be done. Mainly, if the child with growth hormone deficiency becoming an adult, we have to plan where a re-evaluation of patients with childhood or growth hormone deficiency for persistent growth hormone deficiency at the end of growth. If you have a child with diagnosed with a deficiency in childhood, at the end of growth and puberty, discontinue the growth hormone for more than 1 month. Then, if you have a likelihood of severe growth hormone deficiency, measure serum IGF-1. If it is less than 2 standard deviations, then the diagnosis is confirmed in adult and restart. If it is more than 2 standard deviations, then go for GH stimulation test. I'll be discussing about these different types of GH stimulation test in the next slides. And if the peak growth hormone is low, then restart growth hormone. If the growth hormone peak is normal, then reconsider your diagnosis. And coming to if the low likelihood of severe growth hormone deficiency, undertake growth hormone stimulation test and measure serum IGF-1. Both are low, restart growth hormone. Both are normal, discharge unless risk of evolving endocrinopathy. If the tests are discounted, and you can follow up this patient. So coming to the etiology of adult growth hormone deficiency, we know that 57% of growth hormone deficiency are caused by pituitary adenomas and craniopharyngiomas. And we have childhood becoming adult onset, and hypopituitarium causes like adenoma, Cushing's disease, acromegaly, pituitary atrophy, craniopharyngiomas, benign and aggressive malignant tumors. Then non-tumoral disorders like traumatic brain injury, head trauma, related to sports, subarachnoid hemorrhage, and other causes like Sheehan syndrome is the other cause of hypopituitarism in growth hormone deficiency in adult women. We know that if any structural damage occurring to the pituitary, the first hormones which will be affected are growth hormone and cortisol. These two are the large, they are distributed in a way that these two hormones get disturbed early. So adult onset growth hormone deficiency, timing and diagnosis and treatment is very important. When to evaluate growth hormone deficiency and treat? As soon as growth hormone deficiency is suspected, after all other hormones are fully repleted, if the patient says he doesn't feel back to normal, and after signs of symptoms of growth hormone deficiency occur, you have to look for these. These questions are very important. And are there sufficient data to support the treatment in the completely asymptomatic patient? So each question should be answered separately so that you should have a clear-cut idea in patients in the patients whom you are treating. So we have different tests available for growth hormone deficiency in adults. We have stimulation tests. These are called growth hormone stimulation tests, where you can see that insulin tolerant test, arginine GHRH test, that is growth hormone releasing hormone test. Other is arginine levodopa, arginine and L-dopa. And these tests have different cutoff points for diagnosis of adult growth hormone deficiency. Generally, the ITT test, we are not doing this because it is cumbersome and patient goes into hypoglycemia. The commonly done tests are arginine growth hormone releasing hormone test is a commonly done test. And one more test is called glucagon stimulation test, where glucagon given 1 milligram IM at time 0 and samples are taken, growth hormone and IGF samples are taken 0, 90, 120, 150 and 180. If the growth hormone cutoff of less than 3 microgram per liter gives a sensitivity and specificity of around 97 to 88%. So this is how you have to see this test. And if the cutoff is 2.5, it gives a 95 to sensitivity and specificity of around 80%. So like this, you have to see different tests are available. And we know that growth hormone is regulated mainly by hypothalamus. It has two hormones like ghrelin and growth hormone releasing hormone. Ghrelin acts on ghrelin receptor, and growth hormone releasing hormone acts on the growth hormone releasing hormone receptor, which indirectly release the growth hormone from the pituitary. We have a negative feedback from somatostatin, where somatostatin receptor decreases the growth hormone release from the pituitary. So we have one more drug called masimorin. You can see this ghrelin receptor here. This is orally active ghrelin mimetic that binds to ghrelin receptor on the pituitary gland. So you have, this is approved for FDA use in diagnosis of adults with growth hormone deficiency. You can give a 0.5 milligrams per kg oral solution, and you can collect blood samples at 30, 45, 60, and 90 minutes after administration. The cutoff point of 5.1 nanogram per ml can yield a sensitivity of 92% and specificity of 96%. Mainly, it is as compared with other tests, so ITT. So this test has replaced most of the tests in USA, and massive morelin is available in USA. So this is a ghrelin agonist. You can see that this can be used as a simple growth hormone stimulation test. So which patient do not need growth hormone stimulation test, and you can directly diagnose them as an adult growth hormone deficiency. As growth hormone stimulation test is invasive, you can look for other combined pituitary hormone deficiency. Here in this graph, you can see if you have a combined pituitary deficiency of 3 or 4, you can see that the peak growth hormone is less. That means that automatically, if 2 or more or 3 or more pituitary hormone deficiency are occurring, the serum IGF-1 is less, and they don't need any other stimulation test to diagnose having a combined pituitary or pan hypopituitarism. In this situation, you can directly start a adult growth hormone in the adults. So criteria for diagnosis, as I told you, in ITT, you take as 5.1 microgram per liter glucagon, and masimorin, you take 5.1, and glucagon test, you take 2.5 to 3. In the arginine GHRH test, it differs with different BMIs, because as the BMI increases, the stimulation for growth hormone release decreases. So as I told you, again, I'm repeating, stimulator test may not be necessary if the adults with more than 3 or other pituitary axis are already deficient. In these situations with low IGF-1, you can directly start a growth hormone treatment in these adults. And what are the treatment options for adult growth hormone deficiency? So coming to the features of growth hormone deficiency and why we should treat. There is a decreased lean body mass, decreased BMD, there is a decreased physical performance, and with the increased fatigability, decreased cardiac capacity, the fat distribution changes, there is a glucose intolerance, dyslipidemia, and intima media thickness with increased cardiovascular risk occurs. And there is also psychological issues like low self-esteem, depression, mental fatigue, poor memory, impaired cognition, social isolation, and dissatisfaction with body imaging. All these things related to growth hormone deficiency. So what are the effects of growth hormone replacement in adults? You can see that in this graph, this is a study from JCM saying that there is a positive effect on fat mass distribution, and also HDL cholesterol, LDL cholesterol, total cholesterol, and diastolic blood pressure. And there is a bad effects of insulin and glucose effects are there. And with bone mineral density, you can see that after treating of 2 years of growth hormone deficiency in adults, the JET scores have improved a lot in lumbar spine and also in the femoral leg. You can see that the BMD has improved with good, become more positive towards growth hormone deficiency if you treat them. And also the quality of life and sick day leaves are also decreased with growth hormone deficiency. You can see that the partner surveyed reported significant improvement in the patient's alertness, activity, endurance, and mood with growth hormone deficiency compared to placebo. This is very important. You have a very good data in this. So what are the potential impact of untreated versus benefits of growth hormone replacement and CV risks? First, you see that if you have untreated growth hormone deficiency, you have CV risk factors like increased lipid, glucose intolerance, decreased beta cell function, increased resistance of insulin resistance, metabolic syndrome, and there is a surrogate CV markers like increased inflammatory markers leading to individual CV risks. If you treat the replacement, what are happening? You can see that there is a good improvement in lipids. The only thing is you have hyperglycemia. Otherwise, insulin resistance decreased, metabolic syndrome improved, and also the inflammatory markers are coming down with replacement of growth hormone, and there is an improved CV risk in this situation. So that means that Depending on the different clinical trials, we come to conclusion that in the patients with documented growth hormone deficiency and adults, we have a good data to say that the CV risk is improved with growth hormone deficiency, and still we need a long-term perspective studies to confirm this. We have different treatment options available in children and adults with daily injections at the night given. We have different companies, and nowadays we are coming up with a weekly ones growth hormone also. And the recommended doses are, if the age is less than 30 years, we go with 0.3 to 0.4 mg per day. Or if the 30 to 60 years, we go with 0.2 to 0.3 mg per day, or 2 to 5 microgram per kg body weight, like that. It comes to, and if it is less, age is more than 60 years, 0.1 to 0.2 milligrams per day. In diabetes, obesity, and previous GDM, you still go with low doses. And the target IGF-1 should be between -2 to +2 standard deviations for the given population. So yes, 2019 says that use IGF-1 as a biomarker for growth hormone dosing. And you can see that target serum IGF-11 should be between standard deviations of -2 to +2, and be aware of differences between the challenges in this IGF-1 assays, and they are very difficult to have a good value in this. And what are the parameters you monitor in adults with growth hormone deficiency receiving growth hormone replacement therapy? We have metabolic variables like body composition, weight circumference, BMD, DEXA scan, CV, fasting lipids, physical capacity, glucose metabolism. Look for quality of life, look for questionnaires, different questionnaires, and assessment for adverse events and safety, potential tumor growth and other things you look for. And also look for serum IGF-1 regularly in this situation, like you do it in after 2 to 3 months, then after every 6 to 12 months you can do. So assess and manage other pituitary hormone deficiencies in multiple pituitary hormone deficiency syndromes. And monitor 6 to 12 months interval after achieving maintenance doses. Monitoring should be included clinical evaluation and look for adverse events. And if initial DEXA is abnormal, repeat after 2 to 3 years interval. And if a pituitary lesion is present, perform pediatric MRIs to look for the structure of it. And patient receiving thyroid and glucocorticoid replacement may need to be adjustment of the doses after starting growth hormone therapy. And also, if they're not already receiving growth thyroid or glucocorticoid replacement, they should be monitored for deficiencies, and replacement should be given if needed. So what are the common adverse events or adverse effects you see with growth hormone replacement? The short term are like you have electrolyte imbalances, then you have insulin antagonism effects leading to hyperglycemia and worsening of diabetes. Then you have edema, arthralgias, carpal tunnel syndrome, myalgias, and hyperglycemia, as I told you. Long term, there is a potential risk of induction of cell growth and proliferation, and increased risk of tumor recurrence or de novo neoplasia. But the studies have shown that there is no risk of malignancy with use of growth hormone in long term also. And the adverse events can be minimized by looking at the serum IGF-11 levels within the age-adjusted difference range between -2 to +2 standard deviations. So looking for safety concerns associated with long-term growth hormone replacement. So look for diabetes and glucose intolerance. In this situation, go with low growth hormone doses. Any malignancy, already malignancies are diabetic retinopathy, it is contraindicated. So family history of strong cancer, family history, careful consideration should be done. And previous history of cancer, you have a careful consideration, discuss with oncologist and go ahead with this, with low doses. History of CVD, we have positive effects of CVD risk matters, so there is no contraindication. Recurrence of pituitary edema, there is no relative risk. Increase in risk or relative risk. Cancer, there is no increased cancer risk. And mortality also, there is no increased risk. So what about growth hormone replacement in childhood survivors of childhood cancer? The risk of secondary neoplasms appear increased in childhood cancer survivors, but there is no evidence of growth hormone therapy worsening any active malignancy. So we assume that this is based on patients with acromegaly because growth hormone deficiency is contraindicated in pregnancy patients with active malignancy. And you have to be very careful in considering risk and benefit of growth hormone therapy in childhood cancer survivors with confirmed growth hormone deficiency. So I want to conclude that in growth hormone deficiency, adult growth hormone deficiency, the first point is look for proper symptoms or proper clinical evaluation should be done. Look for combined pituitary hormone deficiencies in this condition. You search for etiology for reason for growth hormone deficiency in adults. If you have a proper diagnostic testing, then you can happily go ahead with the growth hormone replacement in the patients, adults. And the duration of therapy is indefinite. You can continue till how much time they want to give. And also, if you want to reassure the patient, if the patient wants to stop the growth hormone deficiency, this growth hormone replacement in adults, then after 2 to 3 months, most of the symptoms are coming back, and there is the changes in the which have occurred due to replacement are reverting back to the previous condition. So you have to be very careful in this situation. So we have to see the financial status of the patient, insurance of the patient. You have to look for other comorbidities when you are starting about adult growth hormone deficiency. So this is the take home message for today. So adult growth hormone deficiency is a new topic in endocrinology, where we have benefits in the population, certain population, where we have confirmed diagnosis of growth hormone deficiency in adults, and the patients get benefit from the replacement therapy. Thank you.
Thank you, Dr. Mohan. We have Dr. Chong with us. He's a chair for CEMAO. Dr. Chong, over to you.
Hi, Sarab. Thank you, Dr. Mohan, for such a great presentation. It's not a topic that we usually visit, but it's always good to get a refresher course.
Yes.
And what was very interesting was the fact that growth hormone treatment doesn't increase malignancy. I think this was one of the things that we were always very worried about, whether it was malignancy, related. And of course, there was a lot of data. I remember a long time ago on growth hormone in aging people.
Yes.
And has that gone away? This aging people thing?
See, aging is a normal, somatopause is a normal thing. And if you see the growth hormone values or levels and a pool data where with young people, middle-aged with aging, it has a tendency to decrease down. So that it doesn't mean that the aging people have better with growth hormone replacement. And using a growth hormone as an anti-aging agent is not approved. So many illicit drug abuse like sports and endocrine drug abuse, the growth hormone is used as an anti-aging, but there are no specific data to support this. And we have so many adverse events occurring in old people with illicit use of growth hormone.
Yes, that's right. I mean, this has always been a problem. I remember some data from China or something or there was some famous data, but it was discredited eventually. I recall some data a long time ago. But it's good to have a refresher on this topic because it's not something we always visit.
Yes.
Any questions from the floor?
Yes.
Dr. Bukhari.
Oh, thank you very much. First of all, thank you very much, Dr. Mohan. Very comprehensive lecture, and I think you have finished within 25 minutes. No doubt. One thing is very important to make a differential diagnosis, and not only the laboratory test. Basically, I'm a pathologist. Not only we aid the pathology laboratory test, we have to aid the other radiology test and other MRI and other things, because there is a difference in the difference, a little bit difference in the diagnosis of the childhood and in the adulthood. One thing. Another test, I think that is latest test, that is flumestine tolerance test. That is also Messi-Merlin test. These are the more specific tests. Can you let me know what basic tests you do in India?
We generally do random growth hormone testing is not at all advisable.
Yes, it is not recommended. Also, some people do it at the late
But
night, but I think it is not recommended.
you have a IGF-1 test, which is a basic guide. You have a if the patient is having combined pituitary hormone deficiencies, you can directly go for serum IGF-1, where it helps directly have a because the growth hormone is stimulating the IGF-1 in the body. So the source of IGF-1 is from growth hormone. And if you still have a doubt, go with insulin tolerant test. Commonly, we do in my DM days where you admit
Because insulin tolerance test is difficult. You need the specialist people to sit and stand with it because it causes the hypoglycemia, and
Yes.
that cause another problem rather in the diagnosis.
Yes.
My one, you know one of the endocrinologists in Pakistan, that is Professor Abbas, is
Yes.
my family member. He working. He is my younger brother. He is working with. He is my family member.
Yes.
So very important thing. My message. Very important thing is to make proper diagnosis, make the differential diagnosis, because other things sometimes because especially in adults. And
Yes.
my question is that what do you think the prognosis of growth hormone, as Dr. Chong has also said this, that some people replacement not only aging, but what do you think is in the childhood diseases of growth hormone?
So in childhood, definitely the growth hormone, if you have a deficiency, the replacement should be given. The only problem in developing countries about the cost and maintenance of this. And if you have a good insurance company available to the child, it helps a lot in childhood growth hormone deficiency. In adults, in somatopause, we generally don't use growth hormone as an anti-aging agent. It is not recommended.
You have
So
saved Dr. Chong.
yes, so this is my view, sir.
Thank you so much, sir. Thank you so much, Dr. Chong.
Yeah. Yeah.
Thank you. Any more questions for the floor for Dr. Mohan?
So Monica, do you want to say something?
Dr. Mohan, thank you for a fantastic presentation. I think one thing that I just wanted to highlight is that early detection is essential to initiate a therapy because time is of the essence, depending on where you are in the stage of growth. And how is the referral pattern to you? Are you able to catch these patients soon enough? Are you able to educate others to be able to catch them, to be able to send them to you? How do you streamline these patients coming to you?
See, mainly we are now mainly concerned about the multiple growth hormone deficiencies, where the multiple pituitary hormone deficiencies. So we have a good referral system from our neurosurgeon and neurology friends, where we tend to see if they have a one pituitary tumor, post-op tumor cases, or pituitary adenomas, or pituitary macroadenomas, or any craniopharyngiomas. These patients are sent to us to evaluate for the pituitary hormone deficiencies, so that we have a referral pattern from the surgeons, neurosurgeons mainly, which is helping us a lot. But from other territories, we are having a less awareness.
Yes, so I think education of the primary level is very important because they might miss the subtle signs where, you know, that it can be picked up early. But fantastic work. Thank you very much.
Thank you, everyone. And if there are no more further questions for Dr. Mohan, then we thank you very much for this wonderful
Dr. Chong,
presentation. Yes.
Dr. Chong, I and Dr. Mohan was talking before the session. I think what we are planning to do is we are trying to bring Dr. Mohan and another nutritionist from Canada. He will talk, and we will link a session to a real cause of diabetes, early diabetes, and questions which are usually required for general public at a very early stage, and what to eat, everything. So we are trying to open that session, and we'll come back on that. So just to intimate that a session more on a basic of diabetes is also very important. We're planning to do.
Sure.
Thank you, Sarab. And we look forward to hearing from Dr. Mohan on that topic again. And thank you very much, Dr. Mohan, and much appreciated. And I think we'll call it a day right now. And thank you, everyone, for participating in today's session. Thank you so much.
Thank you for
Thank
this
you, everyone.
Thank you, sir. Namaste. Thank you.